Okay, we're going to be talking about the cardiovascular system today. We're going to be talking about some of the structures of the heart, cardiac cell potentials, some electrophysiology, and then the cardiac cycle. So, to get started, I think we'll go over some of the structure and how that goes. And so here I've written this nice diagram. This right here, as you can see, kind of where the blood's going. You're coming into the left or the right atrium, then into the right ventricle. And then this is going to pump out, and these go actually to the lungs. And so then they return back into the left atrium and then through the left ventricle and then pumped out for the rest of the body. More specifically, we're going to go over some of the electro features. So this is conduction we're talking about here. We have the SA node. This guy right here, he comes in at this where you're getting your blood. And he is the pacemaker of the heart. And that's because he has the fastest intrinsic rate. All of these have intrinsic rates independent. This one's around 40, and I believe the Purkinje fibers is around 20. But this one is the pacemaker of the heart because this one is actually setting the fastest action potentials. This one will set it, and the rest of them will actually feel that. And so this is going to set it. It's going to feel it. And it's going to send it over here to Brakeman's bundle. And so what this one does is these two are connected because you want your atriums to feel it. Do a contraction at the same time. So this over here, it says right here, ensures simultaneous contractions in the atriums. So this one's setting the pace. You're sending it into the atriums, and then now you have the AV node. The AV node is very important because the AV node is what connects your ventricles. Your atrium and ventricles are electrically different systems, isolated systems. And so this AV node is connecting them. What's significant about the AV node is it actually delays the action potential from the SA node by around 0.1 to 0.15 seconds. This is just to give your heart time to actually contract the atrium before you actually contract the ventricles. You don't want to do them at the same time. And so the AV node is responsible for making sure, giving them that offset, that delay. So that's more of that. Again, now we're conducting into the bundle of His. And so now we're getting into the actual contraction of the ventricles here, And so we get to the bundle of His, which sends it into the left and right branches. The left and right branches are going to conduct this at an extremely fast rate and then into the Purkinje fibers. And we'll go over the EKG, ECG, and you're going to see more or less how this works. But knowing this anatomy and how this conduction works is going to be really big when it comes to looking at an ECG. So let's look at that actually real quick. Here I have a bunch of pictures we're going to go over. This is your starting out. You're sending an electric potential from the SA node and down. And right now on an ECG, you actually set up a negative terminal and a positive terminal on the person. Right here, this is the kind of their right chest, this area. And this is still their chest. It's below or almost like below the breast, a little bit on the left side. And so they're going to be feeling this. And so this is just a diagnostic tools that you can measure. This is called a lead 2 placement. you can have multiple placements around, so you can basically look at the heart from different angles and see what's actually happening. This is just the one we're looking at. It's the one I would say that's most common, and this is what you'll see on like whenever on like the adrenaline graphics and stuff. This is what you'll see. So your SA node, which starts, it has the fastest intrinsic rate and is the pacemaker of the cell, is going to be sending this action to. I don't really like this picture, but it helps paint a picture for what your graph's doing. But this SA node is going to send it. It's going to go through the Brakeman's bundle, and it's going to fill up your atrium. And that right there completes your P wave. And you're going to see at the end what that would look like. But I have more pictures of where we're going with this. So now you hit the AV node right here. And we finished off there is, so you filled this all the way up, and that finishes your P wave. Then you have a slight delay. That's the AV node delaying it like it's supposed to, the 0.15 seconds. Now it's going to send it down the branches from the bundle of His, down the branches and into the Purkinje fibers. So it sends it down, which again, if we have a negative terminal and a positive terminal, I don't think I explained this already, so this is a great time to do it. When you're going down, your cell is negative, and you got all these positive charges on the outside of the cell, but the inside of your cell has got all these negatives. Well, when you're depolarizing the cell, that means you're sending positives in and making the outside of the cell, you're sending all these more negative, and the inside of the cell more positive. So when you're sending these action potentials, you're actually sending a positive charge on the ECF, or I guess a negative charge to the outside. I'm sorry. You're sending a positive charge into the cell and a negative charge onto the outside of the cell. During an action potential, that's what's happening. So this is sending it in the direction of your positive terminal. So positives are coming in. Now we're sending this potential. It sends only off the left branch this way. And so that's going to cause a slight dip because now you have negative charges coming back at the negative. Then all of a sudden it's going to go down all the Purkinje fibers, which has a net vector this way of negative, right at almost your positive charge. That's going to cause a huge spike. That huge spike is going to come right back down because of this part that's going away again. Bam. It's going away. But now we're finished and we completely depolarize this. That depolarization, when it's done, brings it right back. We're back at membrane potential. Now we have to repolarize the cell. To repolarize the cell, we're going to come right back on. And as that repolarization occurs, we have the cell is getting cell's positive for a sec. Now the negatives are going back in. Negative going to, we have this negative going back in there. So the ICF is getting negative again. The ECF is getting positive again. So you got this positive charge from the ECF because that's what we're monitoring. It's not like we can monitor the in. Then you come over here, and this little spurt down, that's your Q wave. Then you go all the way up. This is your R wave. You come all the way down. This is your S wave. And then back up. We're back at resting membrane potential. Then you come over. Up, 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 up. Down, 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 down. T wave. We'll go through the mechanism of the heart now. And we'll go through some of the cardiac cycle of this. But if we go over, I have this nice note here, the cardiac cycle. So here we went over some of the anatomy, and now we've gone over the ECG, and we went over conduction. Now we're going to go over the actual blood flow through here. So this is the mid to late ventricular diastole. Diastole is relaxed. So we're filling right now. Period of ventricular filling. We're going to be sending blood into the left atrium. Right here. This is the ventricle right here. This is the atrium. So we're filling up the atria and the ventricles right now. As you can see, our arrows, blood's flowing. And pressure is rising. So the pressure in the aorta, pulmonary trunk, is super great right here. And it keeps the semilunar valves closed. So as we're filling this up, pressure is increasing in the atria and the ventricular. Right now, the atrial pressure is greater than the ventricular pressure, so it's actually pushing blood down into this. So blood is going into the heart. So AV valves are closed. Those are these ones. And this one. AV valves are closed. Or open, completely open. Semilunar valves are closed, I meant. Now we have the isovolumetric contraction systole. So ventricles are depolarizing, beginning to squeeze and contract, and they're trying to start push the blood up here. But our atrial pressure and our atrial pressure is now less than our ventricular pressure because this is starting to come up. Our arterial pressure, though, here and here, are still higher than our ventricular pressure. So now both valves are closed. When the AV valve shuts, that makes a lub noise. Lub. Now on our on our ECG, on our ECG, here's your P wave here. Here's your Q wave, R, S, T. This is part of the QRS section. Okay? Ventricles are being, boom, brought up. I think that's mainly R. Now we get to mid to late ventricular systole. Ventricular ejection. Blood actually starts flowing out. Our semilunar valves open. So our atrial versus ventricular pressure, right? Atrial is smaller than our ventricular. But more importantly, the one we're looking at is arterial versus ventricular pressure. And now our ventricular pressure is bigger, and so it's literally opening up these, and so blood can come in. I've written down the pressures here, so you can see kind of in relation to each other that the pressure here is so much than here that it's just going to shove that blood right up. This is still part of your QRS. This is more the R than anything, I think. Then you get to isovolumetric dilation. Our arterial pressure versus ventricular pressure. Same as last time. We're pushing it through. Actually, now at this point, our ventricular pressure is getting low. arterial pressure is getting pretty high. Okay, all our valves close, and then we're trying to send this blood through the body now. This, when the semilunar valves shut, that's the dub sound. So the lub dub sound. That is the cardiac cycle. That's how you're pushing the blood through. This is what the actual heart is doing. Now, if we're gonna look this at more microscopic scale, we're back to here. In your heart, we went over the conduction. Your conduction, all your SA nodes, AV nodes, bundle of His, Purkinje fibers, all of that and such. That has a lot to do with your pacemaker cells. Your myocyte cells are the actual contractors themselves. These guys are just making the action potentials. These ones are the carrying the action potentials. So it's easier if we look at the myocytes first. So, myocytes. They have a phase 4, 0, 1, 2, 3, 4. We're going to go over that real quick. Phase 4. We're at resting membrane potential. What phase is this? Potassium is going in and out of the membrane. Potassium going in and out of the membrane, maintaining a negative charge. These are super negative charges. Like we're talking like negative 90. Because the resting membrane potential for potassium is almost negative 90. I'm trying to remember if it's negative 92 or 96. It's really low. And for us, it's about negative 90. So it's super close to the Nernst potential for potassium because it's extremely permeable to potassium. So these cells are super negative. So as you can see, there's actually no hyperpolarization like we've used to seeing on action potentials. But when we start to depolarize, we have our sodium channels. Depolarizing through voltage gated sodium channels. Then we have the one phase, which is when our rapid polarization begins. That's because our potassium chloride channels are open, sodium channels are beginning to close, inactivated, just like we saw in action potential. So, rapid repolarization. 2, then, this is what is so unique. Why this is so much different is because for cardiac, they have calcium. So this is cardiac system. We open voltage-gated calcium. They're a lot slower than the sodium. And these guys make this little plateau. And the goal is to fill up the cell with calcium so we can do a contraction. Muscles need calcium to do contractions. So we set this little plateau, but eventually repolarization of potassium just overwhelms it. And we go back, and then boom, we're right back to 4. Now, in pacemaker cells, these are significant because these guys truly don't really rest at all. They just sit here. And they're just going, and they're just going, and they're just going, and they're just going. So they don't have truly like a resting membrane potential. There's something close, kind of. We're going to say 4, but is it really 4? We don't really know. Depolarization, same way. 3 is the same. There's just less of it. So, here's some notes. Prolonged action potentials. Can't have continual contractions. External calcium forces. Yeah. We're going to talk a little bit more about the autorhythmic cells. Like I said, there's no real RMP here. Only the 3 phases. And these are all in your SV or SA and AV nodes. These are done with your funny channels. And the reason they're funny is because everything we've seen thus far, they haven't acted like this. So, the sodium channels are open when the cell, or these aren't sodium channels per se, but they're gated channels. these funny channels. And they open when the cell's repolarizing and close when the cell's depolarizing. Like, what? But it's funny, right? Hence, they're the funny channels. So, threshold on these type of cells, they activate voltage-gated calcium. So much of the muscle is calcium. But I have a little note here, so you can see how this is never really truly at a resting membrane potential. As you can see in this picture, this is the normal. So that's what I was trying to get at. Well, we're going to go over real quick the parasympathetic nervous system and the sympathetic nervous system. Parasympathetic goes through the vagus nerve, and it's done by acetylcholine through the Gurk channel. And Gurk sets off protein, rectifies potassium, and I have this little flow chart. Acetylcholine, M receptors, Gurk, potassium outward, resting membrane potential, farther down, further from threshold, flattens the slope. And yeah. Now, sympathetic nervous system go through the cardiac nerves. And you can do this through autorhythmic or contractile cells. In this case, we're acting through autorhythmic. They go through beta 1s because 1s odds are excitatory, and it increases the slopes and lowers the potassium or the calcium threshold. It's just the exact opposite of what's actually happening. So, we went over everything but your STEMIs and your non-STEMIs. We go to Google search here, and we do STEMI versus non-STEMI. See what we have here. I like this one. This one's a great one. This is going back to our ECG, but our non-STEMI is basically, it's an ST depression, non-STEMI, which, as you can see, your QRS segment right here, I guess I can't draw it. Here we go. Beautiful. I'm going to go so we can write on this. Okay, so right here are T, or S right here, and here's our T here. On non-STEMI, this is an ST depression because it's lower. And our STEMI is in elevation. So ST elevation. So non-STEMI is ST depression. It causes ECG. The best baseline goes upward. Both of these are caused by hypoxia. The non-STEMI is not as severe as the STEMI. STEMI is the entire thickness of the ventricular wall is just shot. And it's just getting hard to send that. At this point, if you're in STEMI, like, we're in bad condition. Like, we're flirting with death here. So, So, that was a really good picture. I like that picture a lot. Then we want to go over real quick the inotropy and chronotropy. So, beta 1 adrenergic receptor comes, activates, and we can just go through this whole system. but activates alpha, activates adenyl cyclase, CAMP, protein kinase A, which does all these different things, but everything it does here, duration of contraction, duration of contraction. We're just looking at the end result. You can work your way through why it will do this, but just know if you have upwards protein kinase A, we're going to have lower duration of contractions, and we're going to have increased contractibility, inotropic, inotropic, inotropic. Then with our chronotropic actions of catecholamines, we hit a beta 1, adenyl cyclase, pKa, calcium influx, increased heart rate, increased heart rate, increased heart rate. Ready? Duration of contraction lower, increased heart rate. So now we do negative. So remember, M1, or beta 1s, I mean, excitatory. M1, M2s, evens, inhibitory. So with these receptors, we get a heterodimer, opens the Gerk channels, membrane potential becomes more negative, lower heart rate. Decreases CAMP, lowers current, decreased heart rate. Decreased CAMP, lower calcium current, threshold becomes more positive, farther, lower heart rate. So those are our catecholamines. Yeah. All right. Thank you for the video.